Hello, my name is Michael Seidman. I am a board-certified otorhinolaryngologist head and neck surgeon, which is the fancy name for an ear, nose, and throat surgeon. I've also had subspecialty training in hearing and balance surgery at the Ear Research Foundation in Sarasota, Florida. So I'm a specialist in hearing and balance disorders. You've been referred to me for consideration of an operation to improve hearing in your ear. There are three main types of hearing loss. The first type is something called sensory neural, and that is what we see typically with aging, for example. As you get older, the hearing doesn't work so well. And mostly what we can do for that is to put a hearing aid in. If it's very severe, sometimes children, for example, are born without hearing. That's a severe sensory neural hearing loss. We can put in a cochlear implant. The best type of hearing loss, or the most easily correctable, is that called a conductive hearing loss, whereas there is a problem inside the middle ear space that does not allow the conduction of sound. And that is something that is treatable either with a hearing aid or with surgery. We oftentimes offer surgery as an alternative for people who do not wish to wear hearing aids with conductive types of hearing loss. The third type of hearing loss is that called mix, or a combination of 1 and 2, and 1 being the sensory neural and 2 being the conductive. And that can also be improved upon. So if I have a 70 or an 80-year-old patient who has otosclerosis, which we'll talk about in a moment, then I can do an operation to improve their hearing for patients of that sort, and we have done that many times. It has been determined, usually by hearing tests and oftentimes by examination as well, that the type of hearing loss that you have may be surgically correctable. I'd like to show you a picture, a description that describes this, and essentially it's almost like drawing a line through our head and removing the front part. So if we can make a close-up of this picture here, you can see that this is a picture of the ear, or a cross-section of the ear. This is the outer part of the ear that we all recognize. This is the ear canal. Now, the ear canal and the outer part make up what's called the external ear. This is where, for example, people get swimmer's ear infection. This is also where, for example, there is wax inside the ear. The external ear ends at the eardrum, and then the middle ear begins on the inside surface of the eardrum. And it consists of the three smallest bones in your body, the malleus, or the hammer, the incus, or the anvil, the stapes, or the stirrup, as you may well know it. This is the middle ear space, which gets connected to the back of the nose via the eustachian tube. The inner ear starts on the inside surface of the third bone of hearing, again called the stapes bone, and that's where the problem lies with otosclerosis. So this inner ear starts on the inside surface of this bone, and it consists of the snail shell-shaped organ called the cochlea, which is responsible for hearing, and it also consists of the three semicircular canals, which are responsible for balance. Then this information gets transmitted up to the brain via the nerves. If you look carefully inside here, not only is the hearing and balance nerve here, but you can also see the facial nerve. The facial nerve actually runs right through the middle ear space, which is why it is theoretically at risk at any kind of an ear operation. The other nerve that runs right through the middle ear space is the taste nerve. So there are two nerves that also run through the middle ear space. Now, otosclerosis is a problem that causes fixation of the third bone of hearing, or the stirrup, stapes bone. And there is a little bony growth here that occurs, and that's called oto for ear, sclerosis for hardening of the bone. And it causes this bone not to move well, and that causes a conductive loss. So the sound can come in, move the eardrum, move the first bone and the second bone, but the third bone doesn't move. The operation that I'm proposing is called a Stapes operation, where I remove the third bone of hearing and I put in a small prosthesis. There are some people, and I've been wrong twice out of the last 300 patients, so it's not usual that I'm wrong, but I can be, where the first bone of hearing doesn't move. And I can oftentimes determine that in the office. There are some children that I've operated on that have had the third bone of hearing move perfectly well, but the second or the first bone of hearing have been stuck and not been able to move, and I can also improve upon that. Okay. There are three major types of procedures that can be done if you have otosclerosis. One is a Stapes mobilization, which is what they used to do in the olden days. I still do it now on children, and I almost never do it on adults. The problem with it is that the fixation that we break through by mobilizing the Stapes bone gently can refuse, so I don't usually do that. The second most common operation is that called a Stapes or a stapedectomy, where we actually remove the entire third bone of hearing, including this little footplate structure. The reason I don't do that is I think it's a little bit less safe. Now, that is very controversial, and I will tell you that there are some people who have been doing this for 30 or 40 years that have excellent results doing the stapedectomy. I prefer to do something called a stapedotomy, and that is where I remove the horseshoe portion of the third bone of hearing, and I make a small hole into the inner ear, and I use a laser to do this. So it's more of a no-touch technique, in my opinion. I think there's less risk for serious damage to the inner ear. Because again, once you remove that third bone of hearing, or if you put a hole into that third bone of hearing, you are now in the inner ear and you are risking the balance mechanisms and the hearing mechanisms. So I do a stapedotomy because I think it's a little bit safer, generally speaking. And again, that is very controversial, and I don't want to get into those types of issues, but that is the operation that I do. I have done many stapedectomies, and having done both, I prefer to do the stapedotomy now. What are the risks of this type of procedure if you should elect to have this? Well, the primary risks with any operation are bleeding and infection. Those are usually few and far in between, but on rare occasions somebody can get an infection even though we're doing a sterile operation. To me, the biggest risk is you have the operation and there's no improvement in your hearing. You're no better, okay? And then you still have to wear a hearing aid. That is not likely to have happen. In my experience, more than 95% of my patients achieve an excellent hearing result. There are other risks, and that is, besides the incomplete improvement in hearing, just like an eye doctor has to tell you there's a risk of going blind if they operated on an eye, an ear doctor has to tell you that there's a risk of going deaf if we operate on your ears. The risk of deafness ranges from about 0.3% up to about 5%. In my hands, my experience is that about 0.5%, that is roughly 1 in 200, 1 in 300 will actually lose hearing in the operated ear. Doesn't mean that you'd lose hearing in the other ear, but you can certainly lose hearing. It has happened, but it is extremely rare. But it is one of the more common risks that can be associated with Stapes operation. You may also have some balance problems. Again, we are operating on the inner ear, and if you recall, the inner ear does have the semicircular canals, which is responsible for balance. So almost everybody has a little bit of balance problems. Now, I've had some people that I've done their right ear, and they said, hey, I've had absolutely no problems. They come back a year later, I do their left ear, and they were in bed for a week because they've had balance problems. Most people do not have severe balance problems. They have, if they turn rapidly, they get a little bit lightheaded, or if they bend over and stand up quickly, they might get a little lightheaded. Some people do have some true vertigo, which typically goes away. If the prosthesis that I put in is too long, it can certainly cause some balance problems. The other risk that we alluded to is, again, in the middle ear space run two nerves. One is the taste nerve and one is a facial nerve. So there are many people who experience bitter or metallic taste on the involved side. So if we operate on your right ear, the taste nerve provides taste to the anterior two-thirds. That means the front two-thirds of your tongue. And you can have a bitter or metallic taste. The worst case scenario is I've had somebody say coffee tasted terrible for about 6 months. Usually that goes away. Usually that goes away. It could be permanent, but I've not ever had it be permanent. I do not cut that nerve intentionally. There are some doctors, one doctor, Dr. Shuknik, who has now passed away. He was a very famous doctor, worked here at Henry Ford Hospital for many years, for a couple years, and he cut the nerves intentionally on people because it's right in the way of where we work. So there are many people who did that. I do not do that. I move the nerve out of the way. But even just a very slight little traction on it can cause that bitter or metallic taste. The facial nerve I mentioned also runs through there. There is a risk in any ear operation of causing facial paralysis. I've done more than several thousand ear operations now, and I've never had anybody have facial paralysis from an ear operation like this. You can have an eardrum perforation. That can occur. It's fairly unusual, but it does happen. Many people hear well for the rest of their lives. Some people will have to have a revision operation. That is, the prosthesis can slip, it can move out of position, it can erode through the second bone of hearing, the incus. We crimp it onto the second bone of hearing, and when we do that, it can sometimes erode through that bone. So by doing that, again, most of these things don't happen, but they certainly can happen. What are your alternatives? You don't have to have the operation. You can certainly put a hearing aid in that's not unwarranted. Most of my patients would prefer to have surgery. Probably the reasons are is that we're fairly successful at doing this operation. It is a very high success rate, and most people don't want to wear a hearing aid. I, on the other hand, have some patients who say, you know what, I'd rather not have an operation, I'd rather wear a hearing aid. And that's perfectly fine. That is a good alternative for you. You can also learn to live with the type of hearing loss that you have and not wear a hearing aid at all. Lastly, I'm going to mention something called sodium fluoride. And sodium fluoride is believed to be able to treat some of the problems that are associated if the otosclerosis gets into the inner ear. So some people with otosclerosis, where the third bone of hearing is fixed, that bony growth grows into the inner ear, we can retard or slow that growth, possibly with sodium fluoride. There have been no studies to show that it's really helped improve the conductive hearing loss. I also mentioned some anti-calcium drugs, such as people who have a disease called Paget's disease, where calcium buildup occurs. This is in the research stages, and most people feel that it's not going to likely improve any of the conductive component. That is, it probably won't help the bone move any better, so I don't think it's something that we will be using in the future. If you decide to have this operation, the way that I prefer to do it is under local anesthesia. That is, that they give you some medication, you're sleepy, you're sedated, you probably won't remember too much, but you're still awake. Why do I prefer to do that? A, it's safer for you. B, at the end of the operation, I can whisper in your ear and know right then and there if you are hearing better. Now, I have some patients who absolutely wish to be put to sleep, and I have no problems doing that. I would just prefer for you to be awake if you can tolerate it. If you think you're going to have a really hard time, I would rather put you to sleep so you're not moving and fidgeting, because any little movement, of course, gets magnified when I am working with a microscope. What you can expect if you decide to have this operation is usually a week before surgery. They'll call you in to be seen by the anesthesiologist or one of the nurses. They'll explain a little bit to you about what to expect. They may draw some blood work from you. The day of surgery, actually the night before, the midnight before surgery, you cannot have anything to eat or drink after midnight. That is in case they just don't want you to have any food on board or in your stomach at the time. When you come to the hospital, I do this right here at any of my satellites. I can do it either downtown or at the West Bloomfield region. And what we do is about an hour and a half to 2 hours before you come to the hospital, they'll typically start an IV, ask you some questions. We go off to the operating room. The surgery itself takes about 50 minutes to an hour. I've had them take as long as an hour and a half and as short as 30 minutes, but on average, roughly about 50 minutes to an hour. It does take me about 20 minutes to set things up and 20 minutes to break things down. If you are actually going to be asleep for this, I do use a facial nerve monitor. I cannot use it while you're awake, but anybody that I operate on that goes to sleep for a hearing operation gets a facial nerve monitor. It's just a little strain gauge that goes inside the mouth, so your cheek may be a little bit sore on that side. Most people don't notice any problem with it. And again, that's put in after you go to sleep. If you are awake, we do not use those monitors. I do tape your head to the bed just to remind you not to move, and then you have to pretty much lay still. It's when you talk and you're opening and closing your mouth, just that little movement can cause some cessation of motion that I see, and it makes it a little bit difficult. So we ask you to pretty much just fall asleep if you're going to be awake but sleepy, if you will. After I'm all done with the surgery and I've replaced the third bone of hearing with a prosthesis, the ear is then packed, and that will usually impede the hearing again. I usually leave that in for about 5 to 7 days, on average about a week, and then I remove it at that time. There may be some blood or some dried fluid inside the middle ear space even at that time, so your hearing may not be as perfect as it's going to get. Most of my complaints are that things seem too loud, or sometimes they seem a little bit harsh at first to people when they're starting to hear again. That is a complaint that I love to hear, of course. Many people will notice improvement over the next 4 to 6 weeks after I remove the packing. That's typically as things are healing, things are settling down, scar tissue is being dealt with, blood is coming out of the middle ear space. You should not do any strenuous activity for at least 4 weeks and preferably 6 weeks. So I don't want a lot of bending over, a lot of lifting. I've had some patients feel so good they went and they mowed the lawn the next day and then they paid for it. They were very dizzy a couple of days afterwards. It is a problem if you're doing a lot of throwing up and you're really nauseated. That's a concern. I, of course, need to know about it. Typically, the hospital will talk to you the day after surgery, and I oftentimes call my patients at home a couple days after surgery just to see how you are doing. I have no problems with flying. Usually I tell people to wait about a week for flying. Scuba diving is very arguable. I've had some people that I've done this operation on and I've let them go scuba diving, but that is somewhat controversial. If you have any more questions, I'm going to meet with you now to discuss them with you, and I want to thank you for taking the time to watch my videotape.